we have this hour for our seminar series. Today we're going to have one of our professors here at MIT, David Sontag, and he's going to be also with his clinical collaborator, Stephen Horng. Maybe David, you can go through the introductions. The way we do this is usually like half an hour, like a lecture type, and then we use the other half an hour where the clinical collaborator and our researchers work together. But we can be flexible. David, I don't know how you envision this, so whatever works for you guys, it's perfectly fine. Wait, I think you're on mute now.
Given the virtual format,
exactly.
Well, Steve and I are going to both co-present during, and then we're going to leave the last maybe 10 minutes or so for Q&A with the audience, if that's okay with everyone.
Excellent. So please go ahead, because take the stage yeah.
Great. Well, first of all, thank you everyone for joining us here today. I'm sorry that we can't be in person for today's meeting, but I'm looking forward to seeing all of you soon. My name is David Sontag. I am a professor in computer science and in the Institute for Medical Engineering and Science at MIT. I'm also a member of the J Clinic, and the work I'll be telling you about today has actually been funded by a seed award from the J Clinic to really get us off the ground. And presenting with me today is my close friend and colleague, Stephen Horng. Steve and I have been working together for 10, 15 years now. About the moment I got into the healthcare space, it was because of Steve and with Steve. And we'll be telling you about a work that we have been doing to redesign electronic medical records. And as you'll see in a moment, this is work that is done with a large team of amazing collaborators, both here at MIT and elsewhere. Specifically, I'd like to highlight Monica Agarwal and Luke Murray, who are the two PhD students who have been leading the work that we'll describe. Monica ballpark has been focusing more on the machine learning and natural language processing side of things, and Luke on the human-computer interaction components. And as you'll see, the work that we're doing is really bringing the two together, in machine learning and the HCI. We're also working closely with David Karger, who is a professor in computer science and is Luke's PhD advisor. And we've had many wonderful students work with us over the last couple of years. First, Divya, who was a Master's of Engineering student and really kicked off the work with Monica and Luke, and more recently with Sharon, who's in Europe with us. We have a couple of clinical collaborators I'd like to highlight. Nicholas, who is in emergency medicine with Steve at Beth Israel Deaconess Medical Center, and Urbaz Riaz, who more recently has been working with us on redesigning MedKnowts for oncology. And I'll tell you more about that towards the end. Steve, anything you want to add to this? Anything you want to say about your background?
I think you covered a lot of it. Like David said, I'm an emergency physician at Beth Israel Deaconess. I also lead our clinical informatics training program and lead machine learning integration for our hospital and our network.
Great. So the way that we're going to take you through our talk today, first, we want to give you a little bit of background about current electronic health records and the challenges faced by providers, by patients, and by researchers from working with clinical notes that are generated with the current system. And then from there, we're going to talk about MedKnowts, which is a new system that we've been developing. What you'll be seeing today is our very early work in this, but it's a long-term effort, and we have lots of ideas for where we want to take this going forward, which we'll hint at towards the end. Just as broader context, although today we think about electronic health records or electronic medical records as commonplace, it's really hard to imagine anyone using paper for anything. It actually wasn't that way just a few years ago. So the electronic health records in the United States really reached adoption over the last 10 years. And the market is dominated by commercial players, notably by a few just a couple of commercial players like Epic, Cerner, Meditech taking a large chunk of the market, but also many other smaller ones. And what that means is that we now have both data in electronic form on patients. And now this isn't just data like imaging or laboratory test results, but also clinical notes. And we have the opportunity for machine learning algorithms to use that data both to draw insights and to improve the way that clinicians and patients interact with the healthcare system. So to start us off, Steve will walk us through a couple of vignettes to give us some intuition on what a provider's perspective on the problem is that we seek to solve.
So this is a pretty typical workflow of someone in the emergency department or really in any setting who sees a patient. So a patient comes in, they're 60 years old, and then they come in with chest pain. So the first thing that you got to think about is, well, what is their past medical history? What are their priors? What's their pretest probability based on the medical problems they have? Next slide. So probably the first place you're going to look is in their problem list. This is a place in the medical record that summarizes what medical problems they have. And you can see on this list, under the problems, they have diabetes, they have hypertension, they have hyperlipidemia, they have depression. And then because there isn't a better place where this provides a summary view, people leave random notes like, oh, I have to call the pharmacy back. Oh, by the way, this I probably need to call the sister back, and that's their phone number. So there's both semi-structured data and then a lot of other garbage there as well. And then you'll notice also they have a couple of surgical history. They have back surgery, they've had cataract surgery. For some reason, they've had a colectomy, so someone's taken out part of their colon. And they've also had a valve replaced, and it's mechanical. So if you look back on the problem list, I don't know why they've had a colectomy. So that's an open question. Why would someone just take out someone's colon? Have they had cancer? Have they had some other kind of colon disease? And then for some reason, they've removed their valve and replaced it with something mechanical. So do they have some other heart disease? Do they have rheumatic heart disease and their valves are gone? Do they have aortic stenosis? Which valve was this? It's a mechanical valve. Are they on anticoagulation? So I came in with this question of, they have chest pain. So what medical problems do they have? What was their prior history that might help me determine what their pre-task probability of having a heart attack or other conditions are? And I came to the screen, which was supposed to have summarized those things, but what I found was, in fact, inconsistent information. I found that they had their colon removed, but no medical problem pointing to why that might have happened. And they've had their cardiac valve replaced, but I still don't know why. So what actually happens with these problem lists is, it's a place to summarize patient information, but these are all manually kept lists. And because they're manually kept, they could be really great, or they could not be updated at all. And the truth is somewhere in between. But what it really means is you can't trust it because some information will be there, some won't. And because it's incomplete and you don't know what's missing, you actually end up having to search the entire record to get a complete view of this patient. So I started with what medical problems they have, and I left with a lot more questions. Are they on insulin because of their diabetes? Do they have back issues? Do they have back issues because they've had back surgery? Do they have other heart problems because they've had their valve replaced? Do they have cancer because someone took out their colon? And because they're on a mechanical valve, are they on a blood thinner? And is that in range? And what's their heart history like? So I came in with this with questions, and I left with even more questions. And so now I'm going to go dig for some more data. Next slide. So the next place I might look is it's the Notes tab. This is our electronic medical record at the Beth Israel Deaconess, but this type of view is similar anywhere. You go to Epic, you go to Meditech. It's all kind of the same way. So I'm going to look at notes, and maybe I'll find the information in the last discharge summary. So when a patient leaves the hospital, someone will try to summarize their course. And maybe they have some oncology notes or some cardiology notes where they've mentioned some of these things. So I'm going to go and I'm going to search for the last of each of these records, and then I'm going to read each of these records to try to answer some of these questions. And what I find out is, in fact, they are on insulin. They've had chronic back pain. They've had colorectal cancer, and they've had this surgery, and now they're in remission, but no one documented it. And they've had 3-vessel coronary artery disease, and they're on anticoagulation, but they've had a bleeding episode. So maybe that was switched from apixaban to Coumadin, so they switched medications, or maybe they stopped. You don't really know. So the next slide. So I'm going to look some more. So they have a mechanical valve. So in general, they have to be on some sort of anticoagulation. If they don't, they're gonna throw a blood clot and have a stroke or something else. So if in fact, are they on some sort of blood thinner? And if you look at the medications tab, you'll see that they are in fact on warfarin. But the last note that I read said maybe they got taken off of it or switched or something. So this may or may not be true. Maybe someone changed this and didn't update it. So next slide. So I'm going to check the results tab, and you'll see that the results tab, pretty much anywhere you look, is going to be this tabular view of all of your records over time grouped by the lab name. So you can see this is just a small sampling of a fake patient. All these records are fake, by the way, but is a good representation of what a record would have looked like. And so I'm going to scroll down, and I'm going to try to find this lab value and see its trend. And I'll notice that, in fact, the last INR, so that's a lab value that records a patient's how well anticoagulated, how thin their blood is only 1, which is normal. So they are in fact not taking warfarin. So you had a note that said maybe, then you had a medication list that said they are on it, and then you have a lab test that says there is no evidence that they're taking it. So you came in with some questions, you left a little bit more. And then the next question is, well, what is their heart history? What was the last testing that they've done? Their cath, their stress, their echo. So next slide. So I'm going to go to yet another tab and try to find their last stress, echo, and cath, and try to get the results of that to try to have a global understanding of at least what their cardiac problems are like. Next slide. So I came in with this, and I had to gather this information. I went through 4 or 5 different tabs. I read 6 or 7 different notes just to try to gather some history on this patient before even talking to the patient. And if you look at how long a physician has to take care of a patient, they may have at most 20 minutes for their entire care. That's reviewing every note, talking to the patient, getting a history, doing a physical, ordering all their lab tests, reviewing those lab tests, ordering some more tests or medications or treatments, dispositioning, and then talking to them again. So in reality, you maybe have a minute or 2 or 3 to try to gather all this information. And for this particular patient, all we've done so far is gather some information, but not even all the information that you need to make a decision about what their cardiac risk is. But in fact, there are other conditions that you need to consider as well. Things like maybe they have a blood clot in their lungs causing their chest pain because they're not on blood thinners and they have a history of cancer, right? And that's not even something that you might have thought about before doing a review. So you've got this really branching graph of information that you need. And as you go down each of these branches looking for information, you end up looking for more information. And every single tab shows a different piece of information. It might look like this isn't very well organized, but in fact, it's organized exactly how we capture the data. Unfortunately, that's not very useful for the person using it, who uses the data very differently than how we captured that data. Next slide.
It actually might be useful for everyone in the audience to just try to read that note that Steve wrote on the left-hand side.
Maybe I'll read it for, okay, yeah, sure.
Let everyone try to read it, and then Steve, in a second, why don't you try translating it into English for us? Go ahead.
Okay, so this is by the way, this is actually I wrote this in longhand because otherwise you really wouldn't understand it. And if I was a little bit pressed for time, I would abbreviate this even further. There'd be lots of misspellings, and there would be no punctuation or capitalization. So what this actually says, this is a 69-year-old man with a history of diabetes, hypertension, hyperlipidemia, who had a coronary bypass graft surgery in 3 vessels, history of colon cancer, who had his colon removed and is now in remission, had a mechanical mitral valve replacement, who's supposed to be on Coumadin, so the medication to thin your blood, but isn't actually taking it because his lab value is normal, and he's here for chest pain, and who had a diagnostic angiogram looking at his heart, where unfortunately, for whatever reason, there is still a bit of blockage that they couldn't do anything about because they thought they were too high risk, that they might not survive that intervention. So that small little snippet is something that is absolutely essential to understanding who this patient is, and needs to be gathered in, likely a minute or 2 or less. So as you can see, how we organize the data here is basically pre-EHRs. We had everything on a piece of paper, and we recorded data on that piece of paper. So let's take that piece of paper and make a format of it, and then we'll put it electronically, and that's what an electronic health record is. So it's generated and stored exactly how it is captured, and not really how it's actually meant to be used. So that information is fragmented across multiple screens, multiple different systems, leading to the user to have to integrate this information all in their head. And you have patient summaries, which, because everything is in this unstructured format, have to be manually curated, which means you can never be sure if they're up to date or not. It also means that each of these workflows for both information foraging and integration and decision-making are all manual tasks that have to be done over and over again. But each of these tasks are likely user-specific. And with the multiple interruptions that happen, likely you'll forget to do something because you went down the rabbit hole on one data gathering task, and then you just didn't have time for the other, or we got interrupted and forgot about it.
Great, thanks, Steve. So that gives you one sense. And imagine a patient who has cancer. They may have, and who has been perhaps already treated with a first-line treatment and is now getting, maybe had a recurrence of their cancer, is getting started now on a second-line treatment. There may be many tens, if not hundreds, of notes of progress notes written by the oncologist. There may be notes written by the nursing team, by radiologists, pathologists, social workers, all with valuable information to help answer questions like the ones that Steve was just mentioning in an emergency medicine context. And navigating that from a provider's perspective is extremely challenging. But patients also have a need for clinical notes. So there have been a number of studies in recent years which looked at what would happen if patients tried to read the notes that Steve just showed. What would they both learn from them, and what problems might they identify? In this study I'm showing here, there was a survey sent to 150,000 patients across 80 centers with 30,000 patients responding. When looking at the record of their recent visits, 1/5 of them found errors and was documented. 40% of those were later deemed to be serious errors. So this is an example of an opportunity where patients able to participate more in their healthcare decision-making, review, and summarization of their visits through the lens of their their clinical notes. They may be able to help identify and fix some of these errors. A second big problem facing patients is, what just happened in that visit, right? This happens to me when I go to see, even just my primary care physician, but family members of mine who have been admitted to the hospital and later discharged have so many questions. When the attending came rounding with with the medical residents and they were talking about my case, they said this: what were they talking about? When they sent me home, they told me that I'm supposed to take this medication for X many of days, this percentage, twice a day, 3 times a day. I don't remember the details. Oh, and why was it that they wanted me to take this medication? Patients can very easily forget these important details. Also, follow-up, for example, what follow-up is needed? Do I need to go see, do I need to schedule an appointment with my endocrinologist, follow-up after this visit, and so on. Now, this information is documented in clinical notes, but it's hidden. It's not, and patients looking at their notes is an opportunity for them to really close the door and resolve some of the communications and memory issues that we're just referring to. But yet the notes are also very hard to read, as you just saw in the previous example. In this study, it is estimated that only about a quarter of patients could adequately understand their surgical summary, and 65% of the notes didn't have the appropriate reading level for the patients. Now, this is of course only relevant if patients can actually get access to their notes. And part of what makes our work so timely is that as of 1 year ago, April, or less than a year ago, April 2021, there was a legislation that came into enforcement called the 21st Century Cures Act, which makes all clinical notes in the United States immediately available to patients online. So on the left here, I'm showing an email that was sent to all physicians and staff at Beth Israel Deaconess Medical Center in April of last year. Subject is the 21st Century Cures Act, what every clinician needs to know. And I was really informing clinicians about this big change that was about to happen in the next week, where patients were then going to be able to get access to all of the notes that clinicians are writing, which leads clinicians to ask the question of really, maybe they need to be making changes in how they're writing their notes, recognizing that patients might be reading them later. Now, to put this in context, Beth Israel Deaconess Medical Center was one of the originators of this concept of open notes, of letting patients get access to their notes. And they've actually had this open notes system deployed for very, very many years, and was one of the inspirations for this legislation. But even at Beth Israel Deaconess, there were major changes that happened in April 2021. So for example, before April 5th, 2021, inpatient notes, emergency department notes, genetic testing notes were all not released. But because of this legislation, they were all released, and all released immediately. So now if you go to your patient portal, you can navigate to a tab which will let you see all of the notes written by the doctors during their last medical visits. Moreover, in the very near future, within the next year, again, as mandated by legislation and regulation, these notes must be made available via APIs, so that, for example, an app on your Android phone or Google or Apple iPhone, for example, could be able to pull these clinical notes with patients' consent and present that information for patients. So because of this, we feel that there's also a huge opportunity, not just from the provider side, but also from the patient side. If we can untangle this web of notes and start to make it into something which is much higher quality, is going to have impact on both ends. And it doesn't stop there. It's also really important for researchers. So there are very many projects in this in the J Clinic at MIT, where the research takes the following form. We're going to take a data modality of interest, maybe it's imaging data, maybe it's genomics data or metabolomics data, and we want to ask some questions about future disease progression or about treatment effectiveness using that data. So maybe, for example, you'll take as for example in Adam and Urbina's work, maybe you'll take imaging of a woman's mammogram and want to predict a 5-year breast cancer risk. Or maybe, as in some work that I'm interested in doing on the genomic side, you'll take a patient's single nucleotide polymorphism SNPs data, which you might obtain from from 23andMe or from a biobank like the UK Biobank, and want to ask questions about predicting future phenotypes like future cardiac risk, future diabetes risk from the patient's genomics. In many of these cases, those things that you want to predict are all described in clinical notes in some way, and often in a very confusing way. And if one wants to tackle these prediction questions with machine learning, very often there's an arduous first task of somehow abstracting from clinical notes the relevant structured data you need to do machine learning in the first place. Yet another example is in the oncology space. So here's just a snapshot of some of the things that would be of interest for research, both clinical and epidemiological research, but also machine learning-based research in cancer. You'd want to understand when was the patient originally diagnosed with their cancer? When did they have metastasis? When did they have progression? Each of those items might be written in a different clinical note, whether it be a progress note by the oncologist or a radiology note. You'd like to understand what medications that the patient have. Often the medications, particularly for patients who might be seeking second opinions, getting some of their care at a rural cancer clinic and then going to an academic medical center, information about their past medical history, past treatment will be written in a clinical note. And then symptoms. For example, many important questions about cancer care are asking, well, what's the toxicity of this treatment? Can we predict which patients are going to have that toxicity and so on? And to infer that information, one also has to look at the clinical notes where you can derive symptom information, which is not found anywhere else. And finally, if one wants to ask questions about comparative effectiveness of treatments, which medications work best for whom, one has to be able to control for confounding of who was likely to get which treatments. And for that, again, much of the important information is found in clinical notes. And that has been really a blocking point for research in this field, which we feel has been slowing down all progress. So in summary, the clinical state of clinical notes affects clinicians who have difficulty finding and synthesizing information, patients who need help with follow-up and have difficulty understanding medical jargon, research, which requires structured data, and this last point, which we haven't even spoken about yet, but is AI algorithms, thinking about what are the opportunities for AI, such as many of the methods being developed at MIT, to be integrated into the clinical workflow at the right time, where at the right time is often a function of what's actually going on for this patient at this point in time, what is the provider doing, what are they thinking about, and what actions are they considering taking. And that information is often in the clinical note. So if we have algorithms that can rethink the way the clinical notes are written and the way that doctors can interact with them, then we have many new opportunities for thinking about where we can plug in AI algorithms in the workflow. Now, a question that Steve and I often get is, why do you need clinical notes? Couldn't we have just a bunch of checkboxes, or maybe we could have some very standardized ways of writing notes? And as Steve alluded to in the very beginning, when he was talking about the problem lists, previous attempts at trying to restrict the entry of data into very rigid categories either led to very poor quality data or simply frustration because one was not able to express the information that you need to express. Now, there are some areas of medicine where there has been a move towards standardization, notably in some areas of radiology and pathology, where synoptic reporting is starting to change the way in which notes are written. That may make it easier for machine learning or for NLP algorithms in the future to abstract that for the purposes mentioned. But this is really limited, and we don't think that it doesn't seem feasible to use this type of approach in many other areas, such as oncology progress notes or emergency department notes. Steve, would you like to add anything from what I've said so far?
Yeah, there's something in informatics called the synonymy of language, which is there's a certain coloring of how we write our notes, the tense that we use, the ordering of the words that give additional meaning to the reader beyond just the words themselves. So, for example, a patient with pain in the chest is very different than someone who has chest pain, If I say the patient has chest pain, it probably means I'm thinking this might be a cardiac cause, something from their heart. If I say that they have pain in their chest, I'm probably trying to imply that I don't think that's what it is. And that type of coloring in the wording that we use, the ordering that we use, is scattered throughout the medical record and is incredibly important to understanding the meaning behind the words. So there's this invisible context that is really inherent in the notes that's lost when you have 1,000 checkboxes.
Great. So, our goal is to redesign this whole entire system. And we'll start out by just giving you a brief demo of what we're going to propose. Hopefully you can see this. Let's see. And you should be able to hear something as well, if this works.
MedKnowts is an integrated note-taking editor and information retrieval system which unifies the documentation and search process and provides concise, synthesized views of the patient's medical record. MedKnowts uses contextual autocomplete and automatic methods to identify and highlight clinical terms as the doctor types. MedKnowts uses identified terms to fill in later sections of the note, and MedKnowts links terms to concept-oriented cards, providing doctors with a seamless interface for writing the note and exploring the patient's medical record.
So that's just a high-level overview of what we're going to now do a deeper dive into. So first, we'll tell you about the data entry system of MedKnowts. This was work that was published in a conference called Machine Learning for Healthcare 2 years ago. If you think about an emergency medicine context, and there are a large number of different types of information that be mentioned in clinical in free text. Everything from triage assessment to nursing notes, discharge summaries, and so on. We'll focus for the moment on doctor notes, which are being written during the clinical stay and are a place where a lot of the clinical reasoning is happening. So these are notes that are being written while the clinician is gathering information about the patient and making decisions. The reason why we're focusing on this is because that's also an opportunity for where we can start to do decision support and actually improve many of those processes. So the first of our innovations a few years ago was to develop a contextual autocomplete system. This should look familiar to many of us who use even Gmail or Google search, or your phone for text messaging, where you'll have an autocomplete of what is the next word or sequence of words that you're likely to say. So we developed a language model that I'll tell you more about in a few minutes in order to do this autocomplete in the clinical setting that we described. But it has a couple of big differences. Most notably, we're not auto-completing free text. Rather, what we're auto-completing is structured data. So for example, here you see Coumadin, which is a treatment. And as I'll tell you about in the next moment, this piece of text is normalized to a ontology. So although it looks like text to the clinician, behind the scenes, we're starting to get semi-structured documents. So as the doctor is typing, they've written part of the note already, 56-year-old with type 2 diabetes and fibrillation on Coumadin, complaining of nausea and vomiting, and C. So they type in the letter C. Our algorithms are going to use what we know about the patient from their past medical history. So these are going to be notes that were written by either this clinician or other doctors in the past. We'll use structured data, such as past diagnosis codes, past medication records, procedures that were performed. And our new system will also be making use of the note written up until now in order to predict what is the clinical concept that's about to be written. So it could be chest pain, coughing, chills, and so on. Now, when we designed the system, there were a number of considerations. First, this note is a live document and it's changing over time. So our predictions have to be able to change as well. The system that we'll describe, we have implemented at Bethesda Deaconess Medical Center in the emergency department. Right now, it's only turned on for a handful of clinicians who are more technologically savvy and can help us work through some of the many iteration cycles to improve the design. But that requires that we have stringent security considerations, but also that the computation can work in the setting that we're describing. So the autocomplete algorithms that we'll tell you about are running in the browser, and there were a number of optimizations we had to do to, for example, get our convolutional neural network models to run fast enough in very old Internet Explorer browsers. We need a context-specific domain vocabulary, for which we'll be doing the autocomplete in, and we need that to be integrated into the system and has to be modifiable over time. And this is really important for everything that we do with machine learning together with Steve, which is that everything has to be opt-in. So imagine an emergency department setting where every minute is important, and it's a very mission critical, timely setting. So we can't slow clinicians down, and we can't mess with their workflow. That applies to all clinical settings. And finally, we have many goals. So one goal is to not just to create notes but also to get structured data back behind the scenes. So the structured data that we're currently collecting are of conditions. So those would be diseases typically, laboratory test results, mentions of symptoms. Remember back to the oncology example where I told you that recording what symptoms a patient has is very important, medications, procedures, and so on. And we will, our system currently will color code those in the note, which, as I'll tell you about later, some of the users have found to actually be very helpful with improving readability just by itself. We also allow the note to be written as they would want to write it. So if a doctor would like to write their note saying patient has history of HTN, where HTN means hypertension, we're going to allow those synonyms, those acronyms, to be input into the note, but they're still normalized in the back end. So there's also quantitative information that we allow to be entered. So as the doctor is, as the clinician or the scribe is entering information, if they would like to pull up laboratory test results, we have this concept of a living note. No longer is a note something which is just a piece of text. Now it's something that can be updated, that can pull information from other places and can be updated across time with provenance about where that information came from. So for example, here we see that we're pulling the patient's past glucose, and we're going to be asking about the glucose over the past 6 months. And that information will then be entered in this way I'm showing in the bottom right, where we show the range in the past 6 months, the average and standard deviation, all automatically computed from the data in the electronic medical record, and with a little indicator above it where you see this little gray indicator that could tell us if there might be new information from the last time the clinician has looked at the note.
So,
but you can also imagine, yeah.
Oh, sorry. So you might
just
wonder
to finish with that, and then I'll let Steve jump in. You could also imagine that notion of a living note showing up in other places. So we would like to understand, where did this piece of information come from? If it's a piece of text that might have been copied and pasted from a previous note, we have although it looks like a normal note, we have provenance. We know where that information came from. Go ahead, Steve.
So you might wonder, why would a clinician want to document structured data? And one of the reasons is, well, if I use this system, instead of that laborious process that you saw earlier, going through, you're writing a note, and now I have to leave my note, go to a different screen, find the lab test for glucose, look up the values over this range, remember in my short-term memory what the range is, and then come back and then document it, but then I forgot what the exact dates were. So I'm just gonna guess about what the dates are, or stop and go back and try to find the exact dates. You've got this system where as you're writing, you can also query. And the really cool thing about this is because you're doing that, you can specify exactly the lab test that you have. So you'll see under glucose, there's actually 1, 2, 3, 4, 5, 6, 7, 8. There's more than 8. There's actually probably more that didn't make the list that are lower down, of types of glucoses that are truly glucose. It's a type of lab test, but we can run it on your blood, we can run it on your urine, we can run it in your spinal fluid. or other places, and they're all valid tests that we do in fact do. So you could say the patient has a glucose of 40, but what you don't know is if that value means the glucose in their blood or their spinal fluid. And even in context, for a very experienced clinician, you might not know. And in fact, you might have to go to the source lab test to figure out what this person meant, because it is ambiguous even to a human as to what was meant. And so by using a system like this, you give them value in pulling that data, but in return, you also get this really structured data that's very, very precise of the exact lab value for the exact fluid type and the exact value even.
And so this, I would say, is the simplest example of the new paradigm that we're trying to move towards, which is thinking about writing a note, so generation of text, as a mechanism not just for documentation, but also for querying of information or information retrieval. So here they were just doing information retrieval of the patient's glucose. But in a moment, I'll show you how we can pull up cards that will show on the side, which will pull up information also from past clinical notes. And our current research that we're working on is going to be able to infer what is the intent of what the clinician is thinking about at this moment in time. And it's going to do information retrieval from past notes, try to find exactly the information that they might be looking for, and we'll show that to them on the sidebar in snippets. And that, of course, is going to require quite a few advances in NLP, which is a big focus of our machine learning and NLP research. So just to close, this is a little bit out of date, but to give you a sense of the type of language models that we had implemented in this MLHC paper, we broke down the autocomplete problem into two steps. The first one is using local context to predict when to autocomplete and what type of concept is needed. So this notion of triggering, we conjectured originally was going to be important from a user interface perspective, not attempting to do autocomplete everywhere, but only in places where a clinician is likely to enter in one of those clinical concepts. Secondly, then figuring out what is the exact clinical concept that's being mentioned, and for that, using not just local context, but also past medical history, such as previous notes, as I mentioned earlier. Now, we did a retrospective evaluation of these language models. The way that we did this retrospective evaluation was to first do a retrospective extraction of clinical concepts. So we take notes that were already written, we look to see which clinical concepts were written in those notes. That, of course, requires some NLP to find those mentions. Then we say, okay, if we were to pretend that we go back in time, pretend that the note was being written up until that point of time, how many characters would it have taken in order to find the concept that the clinician would have written? And we could measure both the number of keystrokes and the average precision of the correct concept in that ranked list. We then compared a large number of machine learning algorithms, most notably starting with a frequency-based baseline. So just looking to see which clinical concepts are most often documented. Then looking at baseline linear model, which in many settings is already a strong contender. And then gradually over time improved the methods until we landed on what we call a dual branch neural network, which brings together some of the structured data that you have in the EHR in one branch and the clinical text in the other branch, and then has a couple of layers of nonlinearities to make the final prediction. We found that could substantially reduce the keystroke burden to find the clinical note and increase the average precision. Now, that was a retrospective evaluation. We also, as we mentioned, had deployed this at Beth-Israel Deaconess, and we can look at how many keystrokes it actually took to find the clinical concepts that were entered, and then compare that to the total length of the string that would have been otherwise entered, which would be the total length. And so in orange is that sort of total number of keys that would have had to be typed, and in blue is the actual number that was typed, and we see that it's substantially reduced. Now, what I showed you is just one example of how one could rethink the creation of clinical notes. But to get adoption from the broader clinical community also requires some immediate return on investment. One of the immediate return on investments we showed you in the video is automatically filling in information in later parts of the note. So it turns out to be that there's a lot of redundancy in clinical notes. So for example, one has to list the number of the medications the patient is on, but that might have already been mentioned in other places. The review of symptoms might look at symptoms that had previously been mentioned in the history of present illness section, and we can pre-fill many of those using the structured data that's captured in the fly. So just to briefly talk about the data retrieval, and then we'll start closing. In the very beginning, Steve spoke about that information synthesis work that he has to do as he's working up a patient in the emergency department, which requires manually synthesizing data from many different places. So what we've been developing has been a technique to automatically do that synthesis and show data from many different sources on the sidebar next on the right-hand side next to the clinical documentation screen. And we call these cards. You can see an example of cards showing up here. Here's an example of a card for bundle branch block, where we will automatically pull up laboratory test results that our algorithms deem are relevant for that condition. We'll pull up notes from the patient's past medical history that our algorithms deem are relevant for managing a patient in the ED who has this past condition, and so on. So that presents a number of opportunities for information visualization improvements. It also presents a number of opportunities for using NLP algorithms to pull exactly the right snippet out of the past note to present here, given the limited screen real estate. How you figure out which information to present is a big challenge. We've developed a couple of machine learning algorithms for this. One of the algorithms is using a machine translation type approach to align embeddings of conditions to procedures, which allow us to find which procedures are most relevant to show for each condition. So in summary, we designed MedKnowts in a year-long iterative prototyping process with Bethesda Medical Center, with clinicians and scribes using the system for over 1,000 patients. And then we did a final evaluation and a month-long deployment with 4 scribes across 234 patients. This was work that was published in CHI last year. We found that the users were willing to adopt many of the techniques that we mentioned, but also have strong preferences. So there does seem to be a lot of user-specific preference on how to display information and which of the functionalities to use. We found that Autocomplete improved the speed of the workflows, and was also, this was a bit of a surprise for us, served as a useful educational tool for the scribes. This came up in some of the qualitative interviews that we did. So I'll just skip past this to talk a little bit about what we're doing now, and then we'll finish. So one of the things that we're doing is working on improving the cards. To do so, we're doing a couple of ways to try to do that. One is more of a data-driven approach to see what information is currently documented in notes. And for example, for patients who come in with cancer to the emergency department, what information is synthesized and then mentioned in ED notes, using that to figure out what information we might want to automatically surface in the future. A different approach is via user studies. So Monica and Luke actually went to the American College of Emergency Physicians annual meeting a few months ago and set up a booth there where they interviewed 30 or 40 different emergency medicine doctors to get a sense of what information content they would like to see in cards. What we described is in the emergency medicine context, and an important next step is to start thinking about what would MedKnowts look like in other specialties. So Urbaz, who's visiting MIT for the next 2 years, working with my lab, is spearheading this together with Monica and Luke to think about it in an oncology context. We're also thinking about that patient side of the story. So our long-term vision would be that we could take the semi-structured data that you get out of MedKnowts and just automatically rewrite it for patients so that they could better understand it. This is just one use case. So for example, once you recognize that carbo is a medication, you've normalized it to a medical ontology where that medical ontology has a consumer-facing version of it, which is easier for patients to understand, we just write a simple rule to rewrite that in that simple to read form. Now, because MedKnowts is not widely adopted right now, our first attempts at this actually are not going to be using MedKnowts at all. Instead, Mercy, who's a postdoc in my lab, is working with a team of undergrads to design a Chrome browser plugin to do a lot of this, but using NLP algorithms instead of using the MedKnowts output. And finally, I've alluded to throughout a number of really exciting machine learning challenges, which is what we're working on now. One of the first obstacles that we have to overcome to tackle the machine learning challenge of predicting exactly what information content the clinician needs at what point in time is to start to get good labeled data on that. So we're introducing new logging mechanisms into the electronic medical record in order to much more accurately capture that information. In many cases, that also requires changes to the user interfaces. I'll stop there so we have some time for a few questions.
Thank you very much, David and Stephen. That was that's impressive, the work you guys are doing here. And I think there was a question on the text from Sharma, I believe. She was asking about what languages were you guys using on the autocomplete notes? Did you see this one, David?
Yeah, so the work that we did, we're not using any pre-trained language models. So they were models that we trained on several 100,000 notes at Bethesda Deaconess Medical Center. Our newer work that I alluded to at the very bottom of this slide is making use of very large-scale language models that have been pre-trained on outside corpora, things like GPT-3 or T0, and showing how one can then compile them to actually both run efficiently and improve the performance in a clinical setting.
Yeah. And how long do you think you guys this work can, because it's impressive, you know, like it can take you can iterate here, and so how do you envision this in the long term?
So there are a couple of paths that we need to take. There's definitely a lot of work to be done on the research side, but we are also very interested in understanding how can we commercialize this. So we received a bit of funding from the Deshpande Center to start thinking through what a commercialization of this work would look like, and we're starting to think through which clinical settings would be most interesting from that perspective. So I hope that's a quick answer to your question. Maybe Cheryl asked a question over chat that I'd like to just answer. She asked, would we be interested in speaking to other hospital systems about MedKnowts? And the answer is yes, we would love to. Really, for two reasons. First, a pathway to deployment is going to have to involve building MedKnowts in commercial EMR systems like Epic, and Bethesda Deaconess does not have a commercial system, which is how we've been able to move so quickly on the research side. But secondly, because we're really interested in understanding better other use cases for what we're building.
Mm-hmm.
Pete, go ahead.
Hey.
Pete?
So I remember in the 80s and 90s when electronic medical records started to be available at places like VIDMC. There was a lot of conversation about whether the kind of interface that changed dynamically all the time was acceptable to doctors or not. So maybe this is a question I should be asking David Karger, but has that issue been resolved? Because at the time there was very much this notion that you wanted the electronic record to look like the paper record so that people knew how to navigate it.
Oh, definitely that's gone. No one, there are very few people that remember what the paper record looked like. So that is definitely not a thing anymore. There is, however, there is a question of how acceptable is it for users to have an interactive screen where content is being popped up, where you're getting suggestions in real time. And that's really been a challenge on the UI side of not overwhelming the user, which is why we came up with triggering algorithms so that it didn't trigger on every word. But definitely an open area of research that we're still getting our heads around, of providing enough support but not overwhelming users.
Thank you.
Maybe I'll take Emily's question, and then Steve, you can take the next one. Emily's asking about other places where you could surface information, mentioning that clinical decision-making doesn't necessarily happen while you're writing progress notes. And you're absolutely right, Emily. One of the methods that we're currently working on is to surface cards directly within the emergency department dashboard. You could think about it as analogous to your notion of doing it during morning chart review or during rounds, and really thinking through what are these other places, what are the other decision points where surfacing information at the right time would be valuable is an important part of our next steps.
Yeah, just to build on that, you could think about where you did some sort of like sequence model of I viewed this note and then that note, and then actually, I probably the next thing I want to do is look at this card. And one of the really interesting things about that we've noticed about these cards is that it's able to surface this information that you might not have been looking for in the first place. So it wasn't unusual that I wanted to know their cardiac history, and then it certainly surfaces that they've had X, Y, and Z surgery, and then you go and ask the patient, and you're like, "Did you have this surgery?" Like, "Oh yeah, but that surgery is done. Like, I don't have that anymore." Like, no, you still have a mechanical valve. It's still in you. That's still a problem. So there's oftentimes a disconnect, even from getting history from a patient, that this automated surfacing is really able to do something that we just weren't able to do before.
Andrew's asking a very interesting question about potential bias that could be introduced through the use of suggestions of any kind in a clinical setting. And it's definitely something we've been thinking about. It's something that we're very eager to study as part of the deployment of as part of the research deployment of our algorithms. To give you an example, though, we did do a limited study in some of Steve and my earlier work. A paper whose first author is Greenbaum, where we deployed Autocomplete for chief complaints, which were entered by nurses. Our first evaluation just looked at metrics like what I showed you here, which was how many characters did we reduce typing, qualitative assessments from the nurses. But then later we did a much more extensive review of the data, quality review. And what we found, this was a bit surprising, was that actually the quality of the chief complaints substantially improved through that deployment. And I don't think we should take that for granted. That type of study we need to redo in many new settings.
We also found we could, this is after that study was done, that we could bias people intentionally. So because it was easier to type some things than other things, if we sorted things that we didn't want people to use to the very bottom of the list and made it difficult for them to type it, they in fact stopped doing those things. So we could add disincentives for behaviors that are unwanted. So there's a whole list of abbreviations that are absolute no's in healthcare that you should never use because they cause confusion and they cause errors. We can actually bias people to no longer use this. So a way of changing behavior by just a disincentive, making it harder to do.
Atul asked about, from a deployment perspective, with commercial EMRs, would we build a new EMR system or would we have some overlay to existing commercial ones? It's a question that we're actively exploring. I don't think we intend to build a completely new EMR system. That's an enormous undertaking. Some amount of overlay integration is going to be almost certainly the way forward, but the details remain, and we're very eager to talk to any of you who have ideas about paths forward there.
There's a question on checking the medical notes from the patient standpoint as well.
Yes, it's a good idea. Are there any other questions? So Don, yeah, go ahead.
Yeah, that's a good question. The corpus of UMLS is huge. And if you allowed people to autocomplete anything there would just be way too many possibilities. And oftentimes at a higher level of granularity than a specific clinician would want to document at. So for example, I, as a emergency physician, as a generalist, only really want to document that the patient has a history of breast cancer. I don't want to necessarily document about their particular markers, or if they're this responsive or that responsive, basically a very long list of qualifiers, while a specialist might. So both the ontology that's used as well as the interface terminology really needs to be tailored to the specific use case and the user.
So I think we should start finishing. I
Yes.
just want to know from the team, Monica, Luke, Nico, Sharon, is there something that you think Steve or I might have missed that you'd like everyone else to hear?
I think y'all did a great job.
I was about to say they're not going to let you go tonight. It's too exciting, too many questions. But thank you very much again, David and Stephen and all of you guys, the team. You guys are doing an amazing job here. This project is impressive, and like the more I think about it and how this can be impactful and disruptive, it's so much needed, basically. So it's great to this work that you guys are doing. Happy to be part of this and our little component here as well. Anything else? Any other questions? So let's leave it here. Thank you very much again, and talk to you all very soon.
Bye, everyone.
Yeah. Bye-bye now. Thank you.